Effectiveness of constraint-induced movement therapy for stroke patients. Background. Constraint-induced movement therapy, or CIMT, is a behavioral approach to neurorehabilitation designed to decrease the impact of stroke on the upper limb function of individuals that are survivors of cerebrovascular accidents, cerebral palsy, traumatic brain injury, and multiple sclerosis. The constraint-induced movement therapy is composed of a set of rehabilitation techniques that aims to improve and increase use of the more affected extremity while restricting the use of the less affected arm. Constraint-induced movement therapy has three major components. Number 1. Repetitive, structured, practice-intensive therapy in the more affected arm. Number 2. Restraint of the less affected arm. And number 3. Application of a package of behavioral techniques that transfers gains from the clinical setting to the real world, i.e. making it functional. Overview of searching conducted. The databases used were Scholar Google, and UST Online Library. For Article 1, it is the effect of constraint-induced movement therapy on upper extremity function 3 to 9 months after stroke. The Excite randomized clinical trial. Year of publication, 2006. For Article 2, effectiveness of constraint-induced movement therapy in chronic stroke patients. Published in the year 2004. Article 3, effectiveness of constraint-induced movement therapy as home-based therapy on Barthel Index in patients with chronic stroke. Published in the year 2015. Article 4, effects of constraint-induced movement therapy on patients with chronic motor deficits after stroke. Year of publication, 1999. Overview of the methodology of all the articles. Research question and study design. The main objective of syntheses is to determine the effectiveness of constraint-induced movement therapy in chronic stroke patients. The type of research question is intervention. The most appropriate study design according to data is quantitative, according to objectives is analytical, and according to methods is experimental. The study design. Article 1's objectives is to compare the effects of a 2-week multi-site program of CIMT versus usual and customary care on improvement in upper extremity function among patients who had a first stroke within the previous 3 to 9 months. The study design was a prospective, single-blind, randomized multi-site clinical trial. The objectives of Article 2 was to evaluate the effectiveness of constraint-induced movement therapy and dexterity with action research arm test, or ARA test, hand grip strength, pinch strength of affected upper extremity in chronic stroke patients. The study design was a prospective, randomized, observer-blinded clinical trial. The study design was a control study. Article 3's objectives is to investigate the effectiveness of constraint-induced movement therapy on the Barthel Index scores in persons with stroke to assess dependency in survivors of stroke and to investigate the long-term effects of CIMT on dependency needs. The study design was a randomized control study. For Article 4, the objective was to determine whether the result of having large improvements from using a more affected upper extremity in the real-world environment in patients with chronic stroke could be replicated in another laboratory located in Germany, operating within the context of a healthcare system in which administration of conventional types of physical therapy is generally more extensive than in the United States. The study design was a control study. Participants in sampling, data gathering procedures, and statistical analyses. For Article 1, there were 222 individuals with predominantly ischemic stroke. They had a first-time clinical ischemic or hemorrhagic cerebrovascular accident in the previous 3 to 9 months. Patients who have experienced CVA, 9 patients with hemiparesis on the right, and 6 patients on the left side. The independent variable is constraint-induced movement therapy, or CIMT. The dependent variable is upper extremity function. The data gathering procedures or prospective single-blind randomized multi-site clinical trial. An interview, and divided into an intervention and control groups and observational tests as a controlled procedure, as well as a parallel design. Data analysis is analysis of covariance. For Article 2, the participants were 69 chronic stroke patients that were allocated either to CIMT, 33 of them, or conservative treatment, 36. The independent variable is CIMT. The dependent variable is upper extremity strength, specifically pinch and hand grip strength. The data gathering procedures were an observer-blinded randomized control trial and a parallel design. Data analyses were chi-square test, median, range, and percentage of change, Wilcoxon-signed rank test, and Mann-Whitney U-test. For Article 3, there were 27 participants, 16 men with a mean age of 58 and 4 women with a mean age of 60 as the experimental group, 17 participants, 12 men with a mean age of 58 and 5 women with a mean age of 55 as the control group. 24 patients were in the mild group and 13 patients were in the moderate group. The independent variable is CIMT. The dependent variable is Barthel Index score. The data gathering procedures was a randomized control study and a parallel design. Data analyses is unpaired t-test and chi-square test. For Article 4, the participants were 15 adult chronic stroke patients given CI therapy with an age range of 33 to 73. Patients who have experienced CVA, 9 patients with hemiparesis on the right, and 6 patients on the left side. The dependent variable is patients with chronic motor deficits. The data gathering procedures were of an interview and repetition of tests, laboratory, and observational tests as a controlled procedure, as well as a parallel design. The data analysis is the analysis of covariance. Overview of the results of all the articles. For Article 1, from baseline to 12 months, the CIMT group showed greater improvements than the control group in both the WMFT performance time, decrease in mean time from 19.3 seconds to 9.3 seconds, versus from 24.0 seconds to 17.7 seconds, between group difference 34%. In the MAL amount of use, on a 0 to 5 scale, there was an increase from 1.21 to 2.13 versus 1.15 to 1.65. Between group difference, 0.43. P is less than 0.001. MAL quality of movement. On a 0 to 5 scale, an increase from 1.26 to 2.23 was noted versus 1.18 to 1.66. The between group difference is 0.48. The P is less than 0.001. The CIMT group achieved a decrease of 19.5 in self-perceived hand function difficulty, stroke impact scale hand domain, versus a decrease of 10.1 for the control group. Between group difference, 9.42. P is equals to 0.05. CIMT produced statistically significant and clinically relevant improvements in arm motor function that persisted for at least 1 year. Improvements were present following the 2-week intervention, persisted for up to 1 year, and were not influenced by age, sex, or initial level of paretic arm function. The CIMT group had IRA scores, pinch strength of affected upper extremities statistically significant higher than the control group. P is less than 0.05. Then except of the hand grip strength that showed no significant difference. Using unpaired t-test, statistically significant improvement was noted in the BI for the experimental group compared to the control group. After 6 months follow-up, BI was 96.3, indicating that the obtained gains were maintained at 6 months post-discharge compared to their BI scores at 4 weeks post-CIMT. The patient's effect sizes showed a significant and very large degree of improvement from before to after treatment on a laboratory motor test and a test assessing amount of use of the affected extremity and activities of daily living in the life setting. No decrement in performance at 6-month follow-up, and no significant changes during a pre-treatment control test retest interval. Conclusion. The common parameters used for the intervention constraint-induced movement therapy are the following. Number 1. The duration of the test conducted, which lasts for 2 weeks with a maximum of 4 weeks, and the duration of the intervention process, which usually lasts for 6 hours per day. Number 2. Duration and frequency of use of splints. Number 3. Treatment and management, wherein specific tasks and modifications were given to the participants, such as giving a specific splint for them to use, and the provision of training in using the affected extremity. Number 4. Instructions given, such as the usage of splint, home instructions, and reminders to practice at their respective homes for further improvement and progression. Conclusion. The use of CIMT is strongly recommended to patients who had stroke and had experienced difficulties in their daily life because of the limitations brought about by their condition. Based on the results from the 4 articles, significant changes were noted in the upper extremity functions. Number 1 is arm motor function, number 2 is pinch strength, and number 3 is functional performance, activities of daily living. In order to sustain the positive effects of this intervention, training is encouraged at home.